alternative to opioids or adjuvant pain medication. Given that the pharmacology is quite dry for me, I'll be discussing only some of the major medication groups. Antidepressants, they are classified based on the mechanism of action in these groups. Patients, they are already on antidepressants for their mood disorders, or the pain physicians, they start them for the pain relief purposes. Therefore, we need to know from the polypharmacy point of view what these antidepressants pharmacology is. Previously, tricyclic antidepressants, they were tricyclic, but now the new nomenclature is heterocyclical antidepressants. Amitriptyline is the famous drug in this group. It acts by altering the monoamine activity at the synapse and by blocking the reuptake of serotonin and norepinephrine. The clinical effect takes about 2 to 3 weeks to work in. So this is the presynaptic neuron. This is the synaptic cleft and the postsynaptic neuron. So what happens is that the vesicles, they contain the monoamines, the serotonin and noradrenaline. These are released into the synaptic cleft and they work on to the inotropic and metabotropic receptors for their post-synaptic membrane depolarization and effect. Now, what happens is that these vesicles, they are released in large quantities and they go on to attaching to these receptors. But some of them, they are being taken up by the reuptake channel and they go into the presynaptic neuron. This is some of them are metabolized by the MAO enzymes, and some of them are repackaged and recycled into the vesicles and then sent back again into the synaptic cleft. And this is the way the concentration of the monoamines is increased into the synaptic cleft with increase in their effect post neuron. These are the TCAs which are going to act onto the reuptake inhibitor channels. So they are going to block these channels so that these monoamines stay in the synapse for a longer time and act on the postsynaptic receptors. These TCAs, they are quite well absorbed orally, highly protein bound, and liver metabolism and excreted into the urine. The side effects are related to the wide range of receptors that they act on, because they act not only onto the reuptake inhibitors in terms of blocking the serotonin and norepinephrine, they also act on the anticholinergic receptors and also onto the adrenergic and histamine receptors. So their side effects are related to these receptors actions as well. The anticholinergic side effects are quite well known: the dry mouth, constipation, urinary retention, tachycardia, dry eyes, and blurred vision. The adrenergic nausea, the more famous ones are cardiac arrhythmias and orthostatic hypotension, which is even more important in the elderly patient, because once they are started on it, any kind of dizziness may lead to further problems of fall subsequently. Histamine receptor blocking, they are the decrease in acid production, vivid dreams, restlessness, especially if it is taken with the steroids, and it causes a change in the appetite. They do not have any significant drug interaction with commonly co-administered drugs like opioids or benzodiazepines, and very low to minimal abuse potential. However, if they are discontinued abruptly, they may cause problems with increased cholinergic activities such as insomnia or fatigue and GI disturbances. Therefore, whenever they are to be stopped, they should be slowly tapered down rather than abrupt withdrawals. Amitriptyline, the mechanism of action, as explained earlier for the TCA as a whole group, they potentiate the action of the biogenic amines within the CNS, and they inhibit the presynaptic uptake of noradrenaline and serotonin, along with the rest of the cholinergic, adrenergic, and histamine receptors. So they are started slow. They are titrated up, and even if they are to be discontinued, they will be tapered down. They take a few weeks to be clinically effective. Caution is regarding the cardiac conduction, narrow angle glaucoma, and significant prostate enlargement. These are the two neurons again shown, the presynaptic, postsynaptic. Noradrenaline that is released works on the receptors. Reuptake is blocked by the tricyclics, therefore increasing the concentration. Same is true about the serotonin. Increased concentration over here is going to lead to its inhibitory effects. Large volume of distribution has implication on achieving a steady state, and also the magnitude of the dose that will be given to the patient. It gets metabolized in the liver, and its active metabolite is nortriptyline, which is an active and has an effect on the receptors as well, reuptake channels. Since it is metabolized in the liver, so if we get severe hepatic impairment, dose adjustment would be required for these patients. However, if we look at the renal impairment patients, it is not removed by the dialysis, and we do not need any kind of dose reduction for renal impaired patients with amitriptyline. It is highly protein bound drug. So any other drug that would like displace it from the protein, like hyoscine, that would lead to a higher TCA activity or its effect. So likewise, any other drug like barbiturates who would affect the hepatic enzymes or the rate of hepatic metabolism, that would lead to an increase in TCA effect and its metabolism. For any pregnancy-related information on drugs, this is a very useful website, which is UK Teratology Information Service. It provides you detailed information about the from the preconception to the lactation, what kind of like effect any drug can have. So and they update their information quite regularly as well. So this is a very useful, handy site to look into for pregnant patients. The other one is a recent November 2022 British guideline from Rheumatology Society that helps in prescribing the analgesic drugs and their effect in patients who are trying to conceive or are pregnant or wishes to breastfeed their children, what kind of effect that would have on their children. So amitriptyline, if you look at that, they basically say that even that the this parental exposure is like, based on limited data, but mostly it is compatible in patients who are pregnant or are breastfeeding. There is no evidence of adverse effect or developmental outcomes, adverse effects in children whose mothers are taking amitriptyline. Similarly, amitriptyline, it is excreted into the breast milk, and but very small amount is expressed in it, even though the mother would be on the antidepressant dose, which is quite large compared to the chronic pain dose, which is relatively small. So the adverse effect in breastfed children is unlikely. Nortriptyline again is a TCA. It's a good alternative if the amitriptyline side effects are bothersome, especially the lack of energies, orthostatic hypotension. So nortriptyline is considered to be a relatively cleaner drug when it comes to the side effects. The next group is selective serotonin reuptake inhibitor. It works by selectively blocking the reuptake of serotonin, thereby increasing its concentration in the synapse. But then the serotonin increase would have its own side effects as well, especially the GI disturbances. And that you would see at the start of the therapy, and later on when the patient is quite established, they would turn out to be self-limiting in their symptomatology. Again, the same neurons, same thing. Presynaptic, postsynaptic, the serotonin is released over here. The reuptake channel is blocked by the ssri, increasing the concentration and the postsynaptic effect on it. So commonly used SSRIs are fluoxetine, sertraline, paroxetine, and they have a different, they all have different chemical structures. The side effects that you would see would be hypersensitivity and dose-related GI symptoms like nausea, vomiting, abdominal cramps, and diarrhea. But then they are self-limiting as the thing progresses. The CNS symptoms would be the tremor, insomnia, and some psychological disturbances. SSRIs are orally well absorbed, and they are lipid soluble, lipophilic, and have a large volume of distribution. So it takes a longer time for it to reach the steady state. It undergoes an extensive liver metabolism using the cytochrome P450 enzymes. And as we know that these enzymes are affected, induced, or inhibited by a variety of other drugs. And if you look at SSRI, they themselves are quite potent inhibitors of cytochrome, especially the 2D6 and 3A4. Therefore, they are a lot more sensitive to the drug interaction, affecting the metabolism of the drug and its serum levels. Sudden discontinuation would lead to withdrawal symptoms of nausea, vomiting, headache, dizziness, sweat, sleep, and anxiety. Drug interaction with the other drugs that would increase the serotonin, such as those serotonin receptor agonist or MAOI, triptans, they would lead to serotonin syndrome, and that can be potentially life-threatening. How do we, in terms of the symptomatology of the serotonergic syndrome, the way I remember it is that if you look at a very angry person, serotonergic syndrome looks almost like that person: sweating, hypertensive, tachycardic, twitching, so myoclonus and seizures about to fit, that agitation, and probably if it is like too severe, then cardiovascular collapse and death. So there has to be a long drug-free time period between the stopping of SSRI or starting of MAOI, or between the two drugs, basically. How common that serotonin syndrome is, JAMA Neurology 2018 had a retrospective study of about 19,000 patients who were prescribed both the SSRI and a triptan. Now, the combination is normally considered to be by the FDA to be potentially a risk of serotonin syndrome, but they found only 7 cases out of the 19,000 that they studied to have the serotonin syndrome. So it's not as frequent as we would normally think, but since it is potentially life-threatening, that's why in prescribing we have to be aware of this side effect. Now, like TCA, SSRI, they do not have any significant drug interaction that would normally be used with it, like opioid or benzodiazepine. And they have minimal to no potential for abuse. However, the abrupt discontinuation of it may cause a decrease in serotonin that would come out as constipation, or an increase in cholinergic levels that would cause fatigue. So this is avoided by a slow taper off in about a 2 weeks time or so. And like TCS is quite lethal when the people overdose on it, but SSRIs, their overdose is not as serious as TCA. Fluoxetine's analgesic effects, they take about 2 to 3 weeks again to kick in. If a patient is requiring SSRI, then one should use fluoxetine for pain as well as for the mood disorder. So one can talk to their psychiatrist whether for the mood disorder, SSRI or antidepressants which have an analgesic effect, they can be used, because then you can like kill 2 birds with the same stone, like have the antidepressant effect as well as an analgesic effect. But primarily if it is for mood disorder, then it's the psychiatrist who gets to decide whether it would be effective or not for their purposes. But fluoxetine, it is metabolized to an active metabolite, norfloxetine. The other drugs within the SSRI, paroxetine, well tolerated, good as an alternative for TCA intolerant patients, and with some side effects of irritability and tremors, but they have majorly inactive metabolite. Sertraline, again, well tolerated, used for OCD and as well as for analgesic, but active metabolite with no clinical consequences, so that doesn't bother us much. SSRI and SNRI, both of them how do they compare in terms of pregnant patient and those with breastfeeding? So if you can see that even though the evidence is quite limited, but as far as we can see that all of them, SNRI, duloxetine, that is fine, SNR as an SNRI, and all the SSRIs that we talked about, fluoxetine, paroxetine, sertraline, they are all right with the compatible with the these conditions in females. The next group of antidepressant is SNRI. So SNRI inhibits the reuptake of serotonin and noradrenaline. So therefore they increase the concentration of these two chemicals in the synaptic cleft. The ones that are included in this group are venlafaxine and duloxetine. They have different chemical structures, but they are grouped together because of the mechanism that they produce for antidepressant. They have short half-lives and no active metabolism in liver. However, dose reduction would be required for renally impaired patients. Again, same stuff again. This is the neuron which secretes the noradrenaline, and that acts on the postsynaptic neuron. And this is the serotonin one, which acts on the serotonin receptor. Now, TCA is, you can see, is affecting not only the reuptake channels of the noradrenaline and serotonin, but also adrenergic and cholinergic as well. Whereas SNRI are affecting the serotonin and noradrenaline. And if you look at the SSRI, they are selectively in blocking the serotonin reuptake. So all of them together. MAOI, if you want to see, is that just acting on the MAO. So they are the degradation of the already uptaken noradrenaline or serotonin. Their breakdown is prevented by MAOI. So in SNRI, we have venlafaxine. Like amitriptyline, it would act on both the serotonin and norepinephrine, but the relative effect of reuptake inhibition is 30 times more for serotonin compared to noradrenaline. And that too is sequential, so that once it starts acting, it would preferentially work on serotonin first and then later on norepinephrine. And if you increase the dose further, then it would act on dopamine reuptake inhibition. The initial side effects again would be like the way it's sequentially working. It would initially work on the serotonin related side effects, and then it would give the side effects related to noradrenaline as well. Overall, they have a good side effect profile compared to SSRIs. The hepatic metabolism and have an active metabolite. So when it comes down to dose reduction, you would be reducing or causing the dose reduction in both the hepatic and renal impairment for this group. Duloxetine, again, even though it is like venlafaxine, it is working on serotonin and norepinephrine, but the relative effect on reuptake inhibition is 10 times. Instead of 30, now it's 10. So 10 times more for serotonin compared to noradrenaline. This too is in a sequential manner. So first serotonin, then norepinephrine. And hepatic metabolism is undertaken using cytochrome P450. And cytochrome P450 metabolism lends itself to genetic polymorphism and drug interaction via the enzyme inducers and inhibitors. So a lot of inter-individual variability is there based on these drug interactions. Those, since it is metabolized liver, cytochrome P450, so if it is like a severe hepatic impairment, you're not going to use duloxetine. Renal, you will have to reduce the dose of duloxetine for that reason. The next antidepressant is noradrenergic reuptake inhibitor. I haven't used them, so therefore I'll omit it completely. This goes off. Monoamine oxidase inhibitors, although they are not used for pain, and even they are uncommonly used for depression. Reason that we need to know a little bit about them is because of their widespread food and drug interactions. So again, there's a reuptake channel for the vesicles, monoamine, the degrading enzyme. It is inhibited, so more of this is available for repackaging and release. Quite a heterogeneous group of drugs, well absorbed by the mouth and is metabolized in the liver, with the potential that it will damage the liver as well. So LFT monitoring is usually required while patient is on it. Potential drug interactions would lead to excessive adrenergic and serotonergic side effects. So if there is there's a long list of basically drugs that can potentially cause increase of serotonin and noradrenergic reactions. So in that, notably cold medications, carbamazepine, SSRI, and pethidine, that would be one. Next, so we finished with the antidepressants. Next would be the centrally acting skeletal muscle relaxants and their associated drugs. In that, I just picked up on cyclobenzaprine, orphanadrine, and tizanidine. Exact mechanism is not known for most of these. So like they are likely to work centrally at the spinal cord and reticular activating system by depressing the poly and monosynaptic reflexes, and whatever the work that they're doing is more centrally. So the neuromuscular junction and the skeletal muscle fiber level, they are not working. It is well absorbed orally with a rapid onset. Hepatic metabolism with the excretion of its metabolites in the urine. So you would find that there is a lot of significant variability in individuals regarding its duration of action. What I found very interesting was that it has a potential for abuse and dependence. This is something that we really need to watch out for because even though it doesn't raise suspicion, if somebody asks for a benzodiazepine or opioid, we get suspicious about it, but then this is one group that we really don't think too much about it. So sometimes its euphoric effects or its mood altering effects are less than that of benzodiazepine and opioids, but it is if it is used along with it, then it enhances its effects. So easy to get its prescription raises less suspicion. So we need to be more aware. So these are the antispasmodic agents. Cyclobenzaprine, more like related to TCA, antispasmodic it is. And since it is structurally related to TCA, so you can see all the effects are anticholinergic, same as TCA, amitriptyline side effect, anticholinergic properties are there. You would get the same dry mouth, blurred vision, urinary retention, constipation. The caution is same as well as any TCA. Acute angle glaucoma, prostatic BPH, cardiac stuff, recent MIs, you have to be cautious about it. The drug interactions are with the MAOI, so you have to be careful about the concurrent use or the discontinuation time period that one needs to be wary of. Orphanadrine. Orphanadrine is like an analog of antihistamine, diphenhydramine, the famous brand of Benadryl. It's usually in combination with the paracetamol and aspirin. May be used for mood elevation and has anticholinergic side effects again. So they are repeated. Tizanidine is like a closely related to clonidine, centrally acting alpha-2 adrenergic agonist. This is like an anti-spasticity properties. So this is more used for upper motor neuron related spasticity. So it increases the So it increases it. So what it does is like it increases the presynaptic inhibition. So descending inhibition is increased so that the motor neuron firing is reduced and causes a muscle relaxation. It doesn't have any effect on the periphery, which is neuromuscular junction or skeletal fibers. Metabolized in the liver. So one has to be cautious about use in liver impaired or people on long-term or high-dose therapy. You might have to use LFT monitoring on them. Max dose 36, and if you're going to abruptly stop it, people may go into a bit of withdrawal. So if it needs to be reduced, it will have to be reduced by 2 to 4 milligram every day, and monitor the LFTs for it. The drugs that are associated with the muscle spasm, other drugs would be benzodiazepines, diazepam, and GABA analogs, baclofen. Peripheral will just comment on that. So we got benzodiazepine. It is like diazepam. Most of us familiar with it. Mechanism of action is via the GABA mediated inhibition at supraspinal level. So diazepam, being the benzodiazepine, is going to work on the GABA receptors, and the benzodiazepines receptors again are closely linked with the GABA A receptors and facilitate basically the GABA activity, GABA receptor activity. So if you look at this GABA receptor, this is the gamma subunit on which the benzodiazepine acts. It makes it easier for the benzodiazepine to be attached. Benzodiazepine attached with the gamma, making it easier for the GABA to attach, causes the chloride conductance. Increased conductance of the chloride causes hyperpolarization, and therefore it's not easier for it to conduct the action potential. Diazepam, I'm sorry, I'm in the office so you can hear the other voices as well. Hepatic metabolism, and has got active metabolite, and that makes it even a long half-life of about 100 hours or so. It has got well known for its abuse potential, and abrupt withdrawal leads to withdrawal symptoms more or less similar to those that you would see with an alcohol withdrawal. The effects that it would have on CNS is sedation, hypnosis, and amnesia. Give large enough dose, lose an airway, respiratory depression. With long-term therapy of benzodiazepine, people may develop tolerance and dependence on it as well. Orally well absorbed, highly protein bound, and its metabolites are active desmethyl diazepam, oxypam, and temazepam. So these are like the ones that give them a long half-life. If you give cimetidine or any antacid along with it, then co-administration of that would increase the decrease the clearance and therefore increase the plasma levels. The drug is unaffected by the dialysis. So done with it. Ouch. Baclofen. So it's a baclofen's like a GABA analog, and GABA is like an inhibitory neurotransmitter. So it's works by inhibiting the poly and monosynaptic reflexes in the spinal cord supraspinal level. Baclofen's less sedating, but less sedating compared to the diazepam, and therefore it's kind of better tolerated. It got limited hepatic metabolism, and but does have a side effect of sedation, weakness, and confusion. Again, abrupt withdrawal leads to hallucinations and may fit. So if somebody is on a higher dose of say max 40 or 80 milligrams, you're going to titrate it down by 5 milligram every 3 days or so. So I'm like, however rapidly or slowly you titrate it down, but it needs to be titrated down and not completely discontinued suddenly. Next comes the dantrolene. Our familiarities in context of the MH. This is the peripherally acting skeletal muscle relaxant. So, ryanodine receptor inhibits at the sarcoplasmic reticulum and decreases the calcium release, consequent contraction. So again, used mostly for cerebral palsy, MS, so any upper motor neuron related spasticity, it's really, but let's omit all that. Next group, so we've done so far the antidepressants and the centrally acting skeletal muscle relaxants. Now we're going to go into the anticonvulsants. It is classified based on mechanism of action, and those that modulate and those do not modulate the voltage gated sodium channels. So you got phenytoin, carbamazepine, lamotrigine, lacosamide, topiramate. Topiramate would have various actions apart from this one as well. And then those unrelated to the sodium channel would be gabapentinoids, more related to the calcium channels. So based on the mechanism of what channels they are blocking, we have done benzodiazepines as GABA agonist, and you can see topiramate has got multiple actions. Carbamazepine still being used in clinical practice despite all its sins. So voltage gated we'll come to. So this is a presynaptic neuron. If you think about it, the voltage gated sodium channel depolarization, sodium would lead to depolarization and vascular release, which requires calcium as well. So the calcium channel becomes important in it as well, that it is not inhibited. Then the vesicular release, if it is an inhibitory neuron, vesicular release, increased vesicular release will lead to GABA concentration over here and the GABA receptor. So GABA receptor that we talked about, the benzodiazepines working through that. This one, then the sodium channel blockers, the phenytoin, carbamazepine, if they block it, there is no depolarization for the excitatory neurons to be released if it is excitatory one. And the glutamate, which is an excitatory neurotransmitter, they work through the AMPA receptor and NMDA receptor, which are sodium and sodium calcium conductances. Again, that being said, pregabalin and gabapentin not only work through the calcium channel, so the calcium that is being released from here would increase the exocytosis. So that would be inhibited for excitatory neurons. Pregabalin and gabapentin also worked by converting the glutamate into the GABA by working on the enzyme that converts it. So multiple mechanisms by which it would work. Voltage gated sodium channels. So carbamazepine, it is like structurally related to TCA, but actually it is mechanism of action is obviously different. It primarily blocks the sodium, but also has some effect on the calcium channels. Initially, in initial phase, it would have some side effects as well, but they are kind of at the start of the therapy, you would get them, but then as it progresses, people get used to it. Quite a large number of side effects. So to keep an eye on these side effects, what you would need a CBC, renal and a hepatic watch on the patient, because there are renal and liver damages potentially, which may happen along with the anemia. So that's why we would need the testing to be done on these patients. It is metabolized to an active metabolite, and that active metabolite is mostly responsible for most of its adverse reactions. So oxycarbazine came into being mostly because that metabolite is avoided, and therefore it is a cleaner version of carbamazepine. Carbamazepine also induces its own metabolism, so it's an enzyme inducer as well. So it needs to be used a little bit more safely. I'm sorry, I'm just lost track. It is excreted in urine, and the drug itself is not removed by the dialysis. Now the cleaner version of carbamazepine, which is oxycarbazine, again, it is mainly by the blockage of the sodium voltage gated sodium channels, but some inhibition of calcium channel is also done. But the type of calcium channel that we are most familiar with, the L type, it doesn't work on them. It mostly works on the NPNR. So that way it works on two channels. Structurally, it's related. And as I said earlier, it is the metabolite of carbamazepine, which is responsible for all its nastiness, is avoided in this one. And therefore, the side effect profile is much cleaner for this drug. Dose is adjusted for renal impairment, and you can either reduce a daily dose, a half, slowly titrate it up, or the frequency of the dose is changed. Next, we go to phenytoin. Phenytoin, again, exact mechanism unknown, hopefully by the voltage-gated sodium channel membrane stabilizer, mostly known as an antiarrhythmic and an anticonvulsant. The side effects are mainly the metabolic, the idiosyncratic, which we all read in med colleges as well, the gingival hyperplasia that we used to remember very fondly. The concentration dependent side effects are, dose dependent, are the nausea, vomiting, tremors, nystagmus, slurred speech, coordination. So all these things needs to be seen. It is liver metabolized with huge individual variability. Your dose needs to be reduced in hepatic impairment. And it has a very narrow therapeutic index. So that's why the serum levels of it is monitored, especially especially in patients who are using it for as an anticonvulsant. Analgesic wise, the dose is going to be different. Then we have renal, if renal impairment is there, then you won't need, it's not removed by the dialysis, dose reduction would not be required. It's only required for the hepatic impaired. Enzyme inducer with a lot of drug interactions. So if you're having benzodiazepine or pethidine co-administered with it, it would reduce that, the effectiveness of those drugs. Lacosamide and lamotrigine, let's admit that, those are sodium channel blockers. Now, coming to the most commonly used gabapentinoids, gabapentin and pregabalin, they have, although they have a favorable safety profile, but there are concerns about its misuse potential. Abuse is either alone or in combination with opioids because it enhances its euphoric effects. So pregabalin, between the pregabalin and gabapentin, pregabalin is the worst one. It has more abuse potential. It gives you a more better kick, basically. So gabapentin, it came in 1977. Decade later, pregabalin arrived. It's a structural analog of GABA, but it doesn't bind to the GABA receptor A or B. So its pharmacological properties are similar between the two of them. So what do? They modulate the AMPA, a lot of receptors, AMPA, NMDA receptor, and ATP receptors, but most famously, they have high affinity for alpha-2 delta subunit of calcium channels. Now, the two subunits that we have for the alpha-2 delta calcium channels, two subunits, alpha-1 and 2, both of them, it binds to non-specifically. So one is more specific for analgesia and 2 is more specific for side effects. Now there was a talk about, like, a more cleaner version of gabapentinoid coming, which will be more acting on analgesic. So that would be acting more on the subunit, binding to more with the subunit 1 rather than subunit 2. So when it binds to it, the presynaptic receptor, it would cause the reduction in the release of excitatory, that is the glutamate and the substance P. The excitatory goes down and the inhibitory are more released, the GABA is more released, and the excitatory substances are less released, leading to less excitation. Then we come to how we're using it. It is titrated up it is titrated up and for the clinical effect versus the side effect. And even if it is to be discontinued, it will need to be tapered down over a week or so. Otherwise, like, the side effects in terms of the fits and seizures or the anxiety is going to be too high, as it is not metabolized and it is excreted unchanged in the urine. So if there is any hepatic impairment or anything, it doesn't bother us. But if there is any renal impairment, then the dose needs to be reduced. And if the patient is going to be on dialysis, then we would need to give an extra bit post-dialysis supplementation or something to it. So different charts this for renal functions showing that if the creatinine clearances is really low, how much of gabapentin 300 or once a day is a good dose, and post-dialysis a supplementation dose might be needed. And if one needs to start somebody, then like how you can divide it and start it as well. Compatibility in terms of pregnancy and lactation, all good here. Pregabalin. Pregabalin is a GABA analog. It is pregabalin. The additional benefit is that it has got an anxiolysis effect for which it is licensed in UK. It is well absorbed orally and has got high bioavailability, especially in fasted state. The absorption is much better if the patient takes it before in an empty stomach. So dose is to be titrated, and abrupt discontinuation is avoided. So this is an excitatory chemicals, amines, glutamate, neurotransmitter. So if this is the calcium channel. So the calcium channel, if the pregabalin attached to it and blocks it, there's less calcium on here, so less of this excitatory neurotransmitter containing vesicles will be exocytosis, and less of the excitatory chemical will go in, so less of this postsynaptic neuron would be excited, and therefore less transmission of the action potential. Well tolerated despite its side effects. If you see 1/3 of them, probably 1/5, 1/4, my math's bad. Dizziness or solemnness, but other which are very bothersome are the dry mouth, fluid retention, weight gain, and abnormal thinking and memory losses. Memory losses are really pretty bad in these patients. Those who get it, so it's not so uncommon to have that too. If somebody is to be converted from a gabapentin to pregabalin, the conversion ratio is 6:1, which is based on the pharmacokinetics, because pregabalin is 6 times more potent in binding the, affinity than gabapentin. So if you want to convert somebody. Minimal to no liver metabolism, so all good for liver, but excreted in urine, so decrease it down in liver impaired and supplement it further. So again, the same tables, now we're looking for pregabalin. So 75 milligram once a daily dose for somebody less than 15 ml per minute, and post-dialysis supplementation. If you have to start somebody with it, so give initial 25 milligram and then titrate it up, give 75 once a daily dose. Just leave everything. This is like, Faculty of Pain Medicine by Royal College of Anaesthetists. They have got a lot of medication leaflets. This is an excellent resource for patient information, the common questions that patient and the family is worried about, wants to ask, if you want to keep yourself for patient safety netting, basically, that you give them the leaflet or redirect them to the resource, and then they can read up most of the stuff themselves. Thank you. Hello.
Thank you, Dr. Almas. We have a couple of questions in the chat box by some people. Can you see the chat messages?
Ek minute, let me return to the meeting. I can't get out of the screen. It's a learning curve for me now. Why don't you tell me?
Maybe I'll pronounce them right or not, but let me see. Maybe they already answered. Dr. Memoona asked any interaction between tramadol and SSRI. And also he asked, what do you mean by subject to circadian rhythm? Please elaborate with regards to SNRI.
Asha, between the tramadol and SSRI, yes, you have to be like a bit cautious about them. Does increase on increases the serotonin at synaptic cleft, and therefore yes, you have to be careful. Does that mean that you don't give it? No, you just have to like warn the patient about their side effects, start slow, titrate up, and see, watch for the side effects. And otherwise most of the drugs, they do have side effects that otherwise you won't be able to use. Circadian rhythm, actually I did not mention circadian rhythm anywhere, but SNRIs, they are notorious for, especially duloxetine, for causing insomnia. And therefore you would probably, if you take it in that way, that affects your circadian rhythm and your sleep patterns. And that's why you tend, while you're taking the gabapentinoids and other drugs at nighttime, you tend to take duloxetine in the daytime, in the morning, so as not to get too insomnic. And people who are getting too many sleep disturbances, you probably do not want to subject them to further insomnia. I'm sure Dr. KB and Dr. Atiq and all the other people over here, they would be able to talk about it more.
Yeah, thank you. There's another question. Should I go on?
How much time do we have?
Well, this is the
Go
last
ahead.
question mentioned here.
Yeah.
It says, it's from Dr. Waqas. He says, serotonin is the raphe neurotransmitter that triggers phase shifts, inhibits light-induced phase shifts, and this interfering cardiac rhythm. I think he just answered your question, basically. So, and Dr. Sadaf has a question here as well. And do we have dantrolene in Pakistan, oral? We need to reduce the doses of antidepressants in patients with hypothyroidism.
I don't use antidepressants for antidepressant purposes. So I use them for use antidepressants for purposes of analgesia, and therefore my doses are already within the range in which it will not affect hypothyroidism. I will have to seek like if it is given in the antidepressant range of medication, how would that impact hypothyroidism? I don't know. I'll have to see. But I'm not a psychiatrist, so I won't give it.
Okay, well, that's about it from the chat box. And anybody else has any questions? Dr. Waqas is saying, what's your take regarding peripheral muscle relaxants like isopropyl?
I didn't touch much about the peripheral muscle relaxant. I just stick to that one. There's a lot of drugs, I'm sure, peripheral muscle relaxants within this one. This is one. There are others as well. I haven't touched upon. There are, I'm just trying to think, local anesthetics. I haven't touched on steroids. So there's a lot of drugs which are alternative to opioids that I haven't used. Peripheral muscle relaxants, frankly speaking, I haven't explored many locally. I stick to either benzodiazepines or centrally acting tizanidine or phenadrine or cyclobenzapine. I haven't I don't have that many variety of drugs that I have explored. So I would really appreciate if somebody else can answer it.
Assalamu alaikum. अस्सलाम
Assalam.
वालेकुम।
Ji sir.
मेरा
Ji
सारा
sir.
थोड़ा नेट तंग कर रहा था इसलिए मैं बीच में बोला नहीं। तो anyway,
Yes,
it
sir.
was a good presentation, very comprehensive rather. So you have discussed all the drugs. Almas, can you hear me?
Yes, sir. Thank you so much. Thank you for your kind words. I'm really sorry about the net and the everything. I tried to send the recorded version so that it doesn't happen, but in the end it happened. So I'm really sorry about that.
I would say, I would request or suggest to the participants, if they can share their own experience from using these
That would be great.
non-opioid analgesics. If they can share their own experience, so I would, it is very beneficial for the fellows, I think. Is Dr. Jamil Sabit is here? Hello.
Hello.
Hello. आवाज आ रही है?
जी सर आ रही है।
अब आ रही है। क्लास हो रही है। Hello. Hello.
जी सर।
आ रही है आवाज? कब तक नहीं आ रही?
जी सर आ रही है आवाज, आपकी आवाज आ रही है।
तो मैं कह रहा था कि अगर डॉक्टर जमील साहब है तो अपना एक्सपीरियंस शेयर करें of using these drugs. तो जमील साहब थे कि नहीं? आए नहीं?
डॉक्टर जमील
नहीं है।
नहीं है सर, डॉक्टर अतीक है।
डॉक्टर अतीक सुन रहे हैं तो
जी अस्सलाम वालेकुम everyone. So I think everything has been covered by Dr. Almas, a very comprehensive presentation, and almost everything. It's a pretty big topic, but she has touched upon everything. So if we start here, the personal experience that will go along, we won't be able to finish it then, I think. So overall, I think so everything has been covered there. And thank you very much, Dr. Almas. We are looking forward to the next Thursday to talk about the opioids now.
Okay. Then should we leave the meeting? Okay, that's it. Thank you, Dr. Almas. Thank you very much.
Thank you so much. Thank you, sir.
Thank you, Dr. Almas.
Thanks,
Thank you,
Z.
everyone.
Thanks, Z. Apologies again about the disruption.
No, sorry. It was just a last minute and it didn't work out. I'm so sorry about that.
No, it's right. Thanks, Z. Bye.
Take care, everyone. Allah Hafiz.